My name is Gordon Ownby. I'm General Counsel at the Cooperative of American Physicians. And one of the services that I'm really proud to bring to our members is a monthly column called Case of the Month. And in Case of the Month, we look through closed claims at CAP, and we try to find a risk management lesson in those claims so that our physicians can learn from where other physicians have gone and the experiences that other physicians have had with the legal system. There are four major categories of Case of the Month, and they fall into the patterns of physician-to-patient communications, physician-to-physician communications, overseeing what's happening in the medical office, and the fourth category is self-inflicted wounds. Let's take the first one, physician-to-patient communications. Obviously, this is a large area, and the first thing that will come in mind is making sure that the physician has given the patient enough information so that the patient has proper informed consent to go forward with the treatment. And so we have some cases in which, for example, a patient had headaches, migraines, and was seeing her neurologist physician who ordered some tests. And in those tests, there was a suspicion of a brain lesion and possible tumor. The physician didn't want to disclose this news over the telephone, so he planned to tell her about it at the next office visit, which was scheduled for 2 weeks later. Unfortunately, the patient canceled that visit, saw another physician, didn't return to the neurologist for about 8 months. By that time, the neurologist did not even chart a discussion about the possible brain lesion with the patient. And later on, at an emergency room visit, it turns out the lesion had grown considerably and the patient really suffered some bad consequences. Another category that we see involves physician-to-physician communication. And we frequently see errors in communication when test results are communicated to other physicians. In one case, a patient had problems with migraines and headaches, and his physician ordered a Doppler exam. And of course, that was performed by a radiologist. And instead of the radiologist calling with suspicious findings of that Doppler exam, he simply sent the message by fax. And the treating physician ordered another test, a CT scan, and the result was also suspicious, but simply sent to the primary care physician by fax. And when the primary care physician decided to order a third exam, on the morning of that third exam, the patient had a stroke and was not able to perform that exam. And the plaintiff attorney, of course, criticized the physicians for not communicating with each other. And the moral of the story here is communicate in the best way you can when you see serious results. Don't just rely on a fax getting to the physician that needs that information. Pick up the telephone, call, and talk through the situation, because talking through the situation will more likely result in a better plan for the patient. Another area that physicians need to watch out for is what's happening in the office. Obviously, physicians need a lot of assistance. They just can't do it all themselves. But sometimes these assistants go beyond the scope of their duties and responsibilities, usually because they're trying to do good things for patients. But sometimes they do things or they don't do things, and they should have consulted the physician beforehand. There's one case in which a young patient had an allergic reaction in the office of a family practitioner, and that was likely an error because of a misidentification. Basically, there were two young girls with very similar names, and one received the wrong allergy medication. And so she had a reaction that had to be resolved in the office. The interesting thing is that the family practitioner had told her IPA that she did not want to have allergy injections in her office because of the risks involved. However, the IPA employed one of the medical assistants in the office, and the IPA told that medical assistant, yes, you should have allergy injections in the office. And so this physician had no idea that these allergy injections were even being performed in her office. Another area that I write about I call self-inflicted wounds. And in this category, we find cases in which physicians had full control to avoid the event or had full control to lessen the impact of the situation. So if a physician on a patient's admission had ordered a test and during the course of that treatment failed to make sure that test was ordered, and after an adverse event, that test probably would have helped the patient, the physician having written that down and not followed his or her own advice really acts as evidence against himself or herself in a later trial. We've been running Case of the Month in the monthly capsules for about 15 years, and we've decided to choose the best cases for a compilation book called Medicine on Trial. In Medicine on Trial, we go through the major categories such as physician communications, patient communications, following through, watching to see what's happening in the office, and self-inflicted wounds. And we attack those on a chapter-by-chapter basis so that physicians can see several examples of the same phenomenon. And by seeing those examples, we hope that they can adopt risk management principles to help them avoid similar situations.